Members, it's the appointed time and we have a quorum. Let's get started. This is the fourth meeting of the Subcommittee to study population policy and initiatives. Agenda item 1, planning for the medical service needs of the elderly. Let us invite the government representatives to join us first. Members who would like to put questions, please press the Request to Speak button. For this item, we have with us Mr. Eddie Lee, Deputy Secretary for Health, Mr. Leo Lee, Principal Assistant Secretary for Health, Dr. Tony Ha, Assistant Commissioner for Primary Health Care, Dr. W.K. Cheng, Director, Strategy and Planning of the Hospital Authority, and Dr. Sylvia Mann, Senior Medical and Health Officer of the Department of Health. Let me first invite Mr. Eddie Lee, Deputy Secretary for Health, to walk us through the government's paper. Thank you, Chairman. Thank you, members. We have an aging population in Hong Kong, and there is an increasing demand for medical services of the elderly. The Health Bureau, therefore, works proactively to review the healthcare system, and one of the focus is to cope with the challenges brought by the aging population. There are various aspects to our work on promoting primary healthcare services. At the district level, we manage and try to improve the health of elderly people. For instance, we set up the elderly health centers, which provides health risk assessment, chronic disease management, and screening services, and so on. We will also roll out community pharmacy schemes as well as the chronic disease co-care pilot scheme. We also continue to improve the elderly healthcare voucher schemes. In 2023, we already rolled out a series of measures. For example, we expanded the scope of the healthcare voucher scheme. We allowed the co-use of vouchers by spouses, and we increased the voucher amount from $2,000 to $2,500. The additional $500 will be allotted to the elderly person's accounts upon the claiming of at least $1,000 if they spent the money on preventing and managing their chronic diseases. We've also expanded the coverage of the healthcare voucher GBA pilot scheme. Moving forward, we will continue to increase the number of service points covered by the scheme to cover all cities in the GBA to provide more choices for the elderly. On second and third tier healthcare system, we continue to improve our service quality. We have set aside resources and manpower to upgrade the software and hardware of our services to increase the integrated services provided for the elderly. On Chinese medicine services, there is a keen demand for CM services by the elderly. We work with the sector to draft the Chinese medicine development blueprint, and we also formulate appropriate services for the elderly. In 2025, the Chinese Medicine Hospital will commence operation by phases. We will roll out services, for example, services that deal with the mental illness, chronic diseases of elderly people. In late November this year, the LegCo passed the advanced decision on life-sustaining treatment bill, and earlier on, we also amended the coroner's ordinance and the births and deaths registration ordinance. These legislations provide support and services for elderly people who opt for dying in place or who have advanced medical directives. The government has also rolled out measures to increase healthcare manpower supply. For example, we amended relevant legislations to increase the number of training places, as well as measures to introduce non-local doctors, nurses, and dentists to practice in Hong Kong. We'll continue to keep in view with the situation of aging population in Hong Kong, and we will provide adequate services. We are happy to take questions. Thank you. A total of 8 members have pressed the button. They are Mr. Bill Tang, Mr. Dennis Leung, Ms. Nixie Lam, Dr. Chow Meng Kong, Mr. Kwok Wai Keung, Mr. Simon Lee, Mr. Chen Xiu Hong, and Ms. Eunice Yong, Deputy Chair. 5 minutes for each member, questions and answers inclusive. Mr. Bill Tang. Thank you, Chairman. This paper does not really touch on the demand for mainland healthcare services by the elderly people in Hong Kong. By 2039, there will be 2.5 million elderly people in Hong Kong. With such a huge population of elderly people, we expect that there will be an increasing demand for medical services. How does the government address the issue of the demand for medical services in the mainland by Hong Kong elders? How will the government precisely allocate resources to our healthcare system? I'm not saying that we are going to pass on the cost to the mainland. Elderly people, they do not only need dental services. They also need drugs for serious illnesses like cancers. Without insurance, Hong Kong people can get the same types of drugs with a price that is 1/3 cheaper. We have great doctors in Hong Kong, but the costs are high, and therefore a lot of elderly people, they opt to go to the mainland for medical services. Do you have the relevant projections in this regard? We have 9 cities in the Greater Bay Area, and each city faces a different situation in terms of aging population. Even with a residence permit, a Hong Kong citizen cannot take out medical insurance in the mainland. Do you have an idea of the situation of the provision of healthcare services in the mainland? Mr. Lee. Thank you. There are elderly people from Hong Kong who settle in the mainland, and we are facing certain restrictions. Currently, on the mainland, in each province and municipality, there are a group of people who settle in different provinces and municipalities in the mainland. We'll talk to the relevant mainland authorities to get an estimate of the number of elderly people in Hong Kong. For Hong Kong people who need services in the mainland, they do not have to report their address. So we don't have the specific statistics in this regard. Say under the elderly healthcare voucher scheme, that is the voucher scheme in the GBA, we ask elderly people to tell us their residential address. We want to learn from the information to see whether the elderly people live in Hong Kong or in the mainland, and this will give us a better idea. For example, under the elderly voucher GBA pilot scheme, most people who use the healthcare services or vouchers in Shenzhen, they mostly live in Hong Kong normally. But in Zhongshan, for instance, they mostly live in the mainland. On the healthcare insurance, we have learned from the different cities in the GBA. Apart from Shenzhen, most cities adopt the same practice. For example, elderly people who live in the GBA for 6 months, they can get the residence permit and they can take out healthcare insurance. Shenzhen is closer to Hong Kong, and maybe that's why it adopts a different practice. But overall speaking, the practice is the same among the GBA. Mr. Bill Tang, any follow-up questions? All right, thank you. Mr. Dennis Leung. We have a serious aging population problem in Hong Kong. The paper touches on the medical services provided for the elderly people in Hong Kong. How can we do better on prevention so that people, before reaching an old age, they can develop a healthy lifestyle and habit? For example, some people may suffer from dementia. And before they suffer from dementia, can we teach them how to prevent dementia? Also, there are elderly people who suffer from osteoporosis. How can we do more to help elderly people prevent osteoporosis through, for example, their eating habits? Elderly people often have to wait for a long time to receive surgeries, and the long waiting time exerts pressure on the healthcare system as well. On dental services, I don't think we have enough prevention services or oral health services for elderly people or even for the young people. We only offer oral health services for free to primary students. We need to do more on the prevention front to reduce the healthcare expenditure. What is the general direction and planning of the government? Can you do more to compress the healthcare expenditure? We want all people, including the middle-aged, to do more to develop a healthy lifestyle. We want them to do more exercises. For example, I know that the DHC in Kwai Ching, there is a fitness center. However, I don't think a lot of people have been using that fitness center in the district health center. There is only one such district health center in the district. If in each administrative district we can, for example, develop such facilities in the sub-districts in each administrative district, it could be really helpful. Mr. Eddie Lee. I thank Mr. Leung for the comment. In terms of our strategies, we have different reform initiatives within our healthcare system, and the major purpose is to cope with the aging population problem. Mr. Leung is right that we want to adopt a prevention-focused approach. We have set a clear direction for the entire community as well as the healthcare sector that we have to focus more on prevention. In the past, we focused more on treatment. That's why in December 2022, we wrote out the primary healthcare blueprint, which emphasizes a prevention-oriented approach. 1/4 of our current population is elderly people. In the next 10 years, the population of elderly people will reach 1/3 of our overall population. People who reach 50 years old, they could be regarded as an elderly. That's why last year we wrote out the chronic disease co-care pilot scheme. People who are aged 45 or above, they can undergo screening for diabetes as well as hypertension. And we will expand the scheme to cover blood lipid tests. So for people aged 45 or above, we encourage them to focus more on prevention. Around the world, there's been an emphasis on preventing hypertension and diabetes. If we're able to do well in the prevention front, it will benefit the secondary and tertiary level of our healthcare system. Also, we will have to make good use of the district health centers. There are many services for the elderly currently, which educate elderly people about their diet. We also roll out for prevention as part of the education. Elderly people who fall may suffer from dire consequences. So one of the services provided by the DHCs is to educate elderly people on fall prevention. On dental care, like the policy address says, we have dental care services for primary school students. However, we do want the continued provision of services or continued education for secondary school students as well as the middle-aged. So we have oral care services for secondary school students as well. And for oral care services for elderly people, we have the $500 scheme under the Elderly Healthcare Voucher Scheme. An elder who spends $1,000 with their vouchers on dental care can get the additional $500 allotted to their accounts. So this is what we're going to do to focus on prevention.
Next member, Ms. Nixie Lam. Thank you, Chairman. Well, there are elderly appointment quotas, and I do think this is very good. And I think we should also do the same for children. What is the usage rate of the elderly appointment quotas? In the introduction, we know that there will be more elderly people in Hong Kong. Have we used all the elderly appointment quotas? We expect a keener demand in the future. So what are your arrangements? Will you increase the number of quotas? Will you make adjustments? Elderly people may have to undergo different surgeries. For example, for the replacement of knee joints or cataract or diabetes, all these diseases are interlinked. Elderly people use medical services in the private sector. We have the HAGO app. Elderly people have already got used to using this app. Is it possible that we share the relevant information or knowledge through the HAGO app so we can provide services when we invite elderly people to attend talks and seminars? They take a lot of vitamin tablets or pills, or they may even take calcium supplement pills. But an excessive intake of calcium will also be problematic. If we can provide correct information to elderly people, this will ease our medical burden. So let's see if we can make such arrangements. I'll take the second question in relation to the promotion of medical and healthcare knowledge among elderly people. And I will defer to Dr. Cheng for elderly appointment quotas. We understand that we need to enhance our promotion of healthcare knowledge among elderly people. Elderly people share among themselves images, for example, on daily intake of water. This is straightforward and simple healthcare knowledge. We will make enhancements. On HAGO and other mobile applications, we already have been promoting such information. The Department of Health has a relevant promotion scheme. We need to let elderly people know what they have to pay attention to at an advanced stage. For example, for children, for women, there are also areas that they need to pay attention to. So on eHealth, on HAGO, or even in DHC, we will also make enhancements. In relation to the elderly appointment quotas in GOPC, I'll defer to Dr. Cheng. Thank you. We have elderly appointment quotas for some services. Less than 1/3. That was the figure we saw. Right now, the figure stands at 36%. The usage rate stands at around 98 to 99%. In different districts, the quotas may not be used up, but in general, the usage rate is on the very high side. For eye surgeries or for knee joint surgeries, indeed, there is a great demand for cataract surgeries. As mentioned in the policy address, we will strive to provide an additional 20% of cataract surgeries. For knee joint surgeries, likewise, there are a lot of patients waiting for knee replacement surgeries. And we have physiotherapists who can help elderly people to mitigate their pain. We also have, starting from last year, Chinese and Western integrated medicine services. So elderly people can also make good use of CM, that is traditional Chinese medicine services, in order to ease their pain. This year, we organize more talks, say on integrated Chinese and Western medical services, and they need to tread cautiously. There is also information on the internet. Thank you. Next member, Dr. Chow Man Kong. Thank you, Deputy Chair. I have 3 main points of concern. In relation to elderly health centers, every year, for each center, the number of registrants ranges between 8,000 and 10,000. Taipo, Tunmun, Shatin, the wait time may be as long as 4 years. In Kwaichong, it sees the shortest waiting time, but it still takes 1.5 years. So how are you going to deal with this situation? As for EHC, which works on the promotion of health and disease prevention, they will be incorporated into the DHC. In 7 districts in Hong Kong, we have DHC. For the remaining 11 districts in Hong Kong, they are DHC Express, that is, those of a transitional nature. We need to let elderly people know how they can actually solve the problem, so that they'll know how to deal with the situation instead of being scared away by the long queue. Next, on the healthcare manpower projection, in 2040, apart from nurses and doctors, for other healthcare professionals, there will be a surplus, say dentists, 20 traditional Chinese medicine practitioners. For chiropractors, 150, and there are also surplus manpower for other healthcare professionals as well. This is a structural issue. What is the reason behind the manpower surplus? How can we make better use of resources in order to better use healthcare manpower in the community to rise to the challenges brought by an aging population in Hong Kong? I don't want to see this situation happening. Thank you, Deputy Chair. Mr. Eddie Lee, DS. Thank you. On the EHC, that is Elderly Health Center, it has a membership system. So as Dr. Chow mentioned, some elderly people are queuing up to join the Elderly Health Center by registering as a member. There is a long queue in individual EHCs. So as Dr. Chow mentioned, in phases, we'll have to move some services on the EHC to the PHCC, that is the Primary Healthcare Commission. It is working on a new mode. How can we provide these services through NGOs? After all, these services have a high service capacity or quantity. If we stick to the old model, we cannot provide a one-stop shop to handle the demand. So the DHCs and the PHCC are working on a new model to provide better services for the elderly people in Hong Kong. For those elderly people receiving services under the EHC, we want to minimize the changes that they'll have to go through, so they can still keep using the EHC, and we will, in phases, move some services on the EHC to the District Health Center DHC under the Primary Healthcare Commission. In relation to Manpower Commission, we take a scientific approach. The HA has been coordinating among different healthcare professionals. We also take into account the population growth and the school places of the healthcare profession in Hong Kong. For individual healthcare profession, there may be a manpower surplus in the long run. We are still expecting a medical healthcare surplus in the future. Will it be still the same in the long run? We'll have to wait and see. Dr. Chow, up to 2039, the proportion of elderly people will rise to 1/3. Right now, the figure is 1/4 of the overall population in Hong Kong. I'm not saying that you aren't taking a scientific approach, but against this backdrop, and we're still seeing a long queue in the future right now, so we shouldn't waste public resources. We want to allow non-locally trained dentists to provide services in Hong Kong. That is, we talked about the DRO, Dentists Registration Ordinance. So probably the administration can provide the relevant information on medical healthcare surplus to Dr. Chow after the meeting. Thank you. Next member, Mr. Kwok Wai Kung. Just now, my party colleague, Mr. Bill Tang, mentioned cross-boundary elderly healthcare services. We do need to work harder on this front. The retirement life of elderly people is important to us. We also care about their mental health. I understand we only have the Health Bureau, the DOH, as well as the Hospital Authority joining us today. There are no colleagues under different bureaus. My question may relate to different bureaus. When it comes to mental health in the community, many elderly people say that they have a lot of different diseases upon retirement. Upon retirement, they have nothing to rely on, nor do they have a social circle. They don't have any interests either. So all of a sudden, their mental situation or mental condition deteriorated. For silver hair employment, it is not just a policy. Many stores in wet markets say that they don't have a lot of business volume, but then they are still operating their stores. They need to kill time. They also want to keep their social circle. So we shouldn't just talk about healthcare and social benefits. We also want to place emphasis on silver hair employment. It is also part of mental health. In the front line, we received information from elderly people living in public housing estates. We have wealthy tenants policy, so quite many public housing estates have turned into housing estates that comprise primarily elderly people. They don't have any income. So for these elderly housing estates, so to speak, apart from seeking medical attention in the public sector, there is a stable and a high demand for medical services within the housing estates. There are doctors in the housing estates, but the doctors may also retire soon. In some public housing estates, there used to be 3 to 4 doctors, but right now there's none. Some may have already retired, or some may have already left the housing estate. In some housing estates, there's not even one single doctor. So the administration may have to see how to solve this problem. There's a long queue for public medical services. Some elderly people may want to seek medical attention in the public housing estates, but then there is no such service in the housing estates in which they live. My next question may not relate to the Health Bureau. How can we make sure healthcare information can reach elderly people in Hong Kong? There are day activity centers, but we want to disseminate information to elderly people in Hong Kong more proactively. We don't want to see elderly people being scammed. They may lose their lifetime savings. We need to disseminate information in order to help them. Thank you.
好，你秘書長睇下答唔答到？
Deputy Secretary, the points raised by Mr. Kwok, they seem to be irrelevant to the healthcare policy, but please be rest assured that we are working as one government. The Social Welfare Department as well as the Health Bureau have been working together. For example, we have the elderly health centers of the Health Department. We also have the elderly centers as well as neighborhood elderly centers. So we've been coordinating with each other in terms of rolling out these services. For discharged elderly patients, we also have medical social collaboration schemes to follow up on those patients. On community services, the Department of the Hospital Authority as well as the Health Bureau have visiting health teams. And we will also step up collaboration with the Labor and Welfare Bureau. So please be rest assured that there is coordination among different departments and bureaus, and understand that for the second agenda item today, there will be representatives from the Labor and Welfare Bureau. Mr. Simon Lee, Thank you, Chairman. My first question is similar to the question asked by Dr. Chow Man Kong. As the government plans for the medical service needs of the elderly, I understand that you have been very innovative and focus on prevention instead. Have you made an estimate on the reduction of costs by rolling out all the different healthcare initiatives? You have to look at the demand and supply as you plan for the medical services. That's my first question. Paragraph 14 of the paper mentions that there is the University of Hong Kong Shenzhen Hospital, where there are Hong Kong doctors who prescribe Hong Kong drugs for patients. Would you be able to expand such services so that elderly people from Hong Kong can benefit from that? The third point I want to make is about early prevention. As mentioned, people aged 45 or above can undergo screening for diabetes and hypertension. Doing sports and exercise can help prevent diseases as well. I understand the government has been encouraging people to do more exercise. However, it seems like the promotion of sports has not been really linked to the healthcare services of the elderly. I wonder if the government can do more in this regard. Mr. Lee, on the planning for the medical service needs as well as the estimate of the associated cost effectiveness. Well, as mentioned, we have the chronic disease co-care pilot scheme to help manage people's diabetes or hypertension situation. We've already commissioned a university to conduct a study for us. We want to look at, after allocating resources into this, we might be able to reduce the risk of complications as well as healthcare expenditure. So we are trying to make an estimate through the study on the measure of using Hong Kong drugs in the mainland. Currently, there are 45 mainland institutions where over 40 types of Hong Kong registered drugs are used. We will continue to talk to the relevant mainland authorities about this. In terms of the use of Hong Kong drugs, they are being used in the mainland institutions. We are happy to see that more Hong Kong registered drugs are being used in the mainland. On the promotion of sports, the Primary Healthcare Commission will promote sports therapy. We want to help young people to enhance their mental health through sports therapy. We want to do the same for our elderly people. For example, the fall prevention education I mentioned falls under sports therapy as well. So on the primary healthcare level, we've been stepping up efforts in this regard. Mr. Chen Xiu-hong. Thank you, Chairman. The paper mentions that the SAR government has been planning for the medical service needs of the elderly. A number of members, including Mr. Simon Lee, asked this question about planning. We need projection. Without projection, we cannot ensure a good planning. So I'm happy that the government is, through different initiatives and measures, including the different pilot schemes, going to carry out studies. The government is adopting the early prevention and detection approach. And the government is trying to find out how this helps alleviate the burden on the private and public healthcare sector. Without the projection, I'm afraid that this paper is just showing the initiatives implemented by the government after the promulgation of the primary healthcare blueprint in December 2022. So I hope that the government can get the results of the projection soon, and that the data collected by the government can help it plan the medical service and decide in what areas the government needs to improve on. I have the following questions. We see an increasing demand for medical services of the elderly, and there is a higher burden on the public healthcare system. We have an aging population, and as a result, we are seeing an increasing demand for services. There are 20 to 30 mentions of public-private partnership in the primary healthcare blueprint. However, this is not really being touched on in this paper. I believe the public-private partnership model can help alleviate the burden on public healthcare system. For patients with chronic illnesses or general members of the public, every 2 to 3 months they have to go to the public hospitals or clinics for medical consultation. This is a huge burden for people. Have you assessed the effectiveness of public-private partnership? I think we need to expand this model. The thing is, we have to think about how. Elderly people and young people have told me that they cannot choose their own family doctors. They have to have the hospital authority select the doctors for them to monitor their situation about hypertension or high blood pressure or blood lipid level. Can you adopt a private partnership, public-private partnership model to help alleviate the burden? Mr. Lee. We emphasize the PPP model. This is because we cannot solely rely on the manpower in the public healthcare sector, so we want to leverage the private sector forces. On primary healthcare, the elderly healthcare voucher scheme can be seen as a public-private partnership. Every year we give $2,000 for our elderly people through the vouchers so that they can enjoy services from 13 to 14 medical professions. We also have the chronic disease co-care pilot scheme to perform screening of diabetes and hypertension. Through government subsidies, people pay a co-payment fees with family doctors who carry out the screening. As mentioned by the primary healthcare blueprint, there will be more subsidy schemes for elderly people as well as for women at the community level. Those schemes will not be run by the government. We aim at making use of the private sector in running these schemes. Mr. Chen also asked about PPP in general outpatient services. We refer patients from the hospital authority to the private sector. We need doctors to ensure that the patients are clinically stable before referring those patients to the private sector. However, if the clinical situations of the patients are unstable, we have to rely on doctors to make a judgment. On adopting PPP for specialist healthcare services, one of the considerations is that if we outsource the services to the private sector, we might lose manpower in the hospital authority.
Thank you. A quick follow-up. We need to be cautious with the assessment. For those with 3 highs, for those who need to get medicines every 3 to 4 months, they will have to travel far and take some time to go to the hospital to get drugs. Some elderly people are actually in a stable condition, so the HA may make arrangements for these elderly people to seek medical consultation in private hospitals. But then this service is only for those who are invited by the HA. The patients cannot opt for such services. But if some patients are stable, they meet the requirement, why don't you provide PPP for these elderly patients? Well, Mr. Chen, if possible, you can speak in the second round. You've used all your time in the first round. Next member, Deputy Chair, Ms. Eunice Yong. Thank you, Chairman. I agree that we need to focus on prevention. In the documents, I can see that prevention has to do with fall prevention. But what about dementia and the 3 highs? How can we prevent such diseases? What measures are in place? I don't see the determination of the administration. How can we leverage on technology to prevent diseases? We're using DHC, and we're going to promote community pharmacy programs. But in mainland China, there are many successful examples, say remote telemedicine, video telemedicine. All these are being implemented. But in this regard, we are quite slow. Science Park, Sabaport, or for the Donghua Group, there are technologies to help elderly people or to help the middle-aged to prevent diseases. How can we be psychologically prepared for the aging population? I'd like to ask the DS in this regard, how will the HA to promote and implement technology medicine, and how can we promote technologies in relation to disease prevention? How can we fare better in this regard? Thank you, Chairman. We understand technologies need to be promoted in different walks of life. For many screening programs, we need to have face-to-face consultation for the screening exercise. Honestly, there are large-scale organizations in mainland China. We work with them. We're in talks with them. We're drawing reference from the large systems. How can we promote health to using telemedicine to getting medicine? How can we provide a one-stop shop to have all these services at one go? We have our own constraints. For example, During the pandemic, we made changes to the rules in relation to telemedicine consultation. We have already built platforms, say HAGO eHealth. There are over 5.9 million people using eHealth. We'll draw reference from members in view to see how we can make improvements. It'd be better to use eHealth. If there are too many healthcare related applications, they may be too fragmented. So how can we consolidate all healthcare services provided by the administration into eHealth? That way we can provide a one-stop shop. We can also disseminate healthcare information to the public on this app. Hong Kong people can also manage their physical conditions. For example, I myself also checked my BMI on the eHealth app. Thank you, Chairman. I agree. We do need to make good use of existing platforms, say the HAGO and eHealth. The administration should also make good use of local technologies. Local students have developed apps to conduct health assessments or mental health assessments. They may be for children or for the elderly. We can provide information to carers. We can also provide information on fall prevention. Above all, we need to make good use of local information. When we have the app available, we do want to see Hong Kong people using these apps. We need to encourage millions of Hong Kong people will use the eHealth app. DS. Thank you, Chairman. Thank you, Member. We'll draw reference from members in view in relation to the promotion of healthcare information. Next, Mr. Benson Look. According to the CNSD, the proportion of elderly people in Hong Kong will rise from 1.64 million to 2.67 million in 2043. In other words, over one-third of the local population will be elderly people. So we need to plan in advance in order to rise to the challenges brought about by an aging population. In the document, there's coverage dedicated to elderly healthcare voucher scheme. The figure rose from $635 million to $1.1 billion, an increase of 8%. It's the second highest among all the grants. CM services account for some one-third resources. Therefore, we can see that traditional Chinese medicine services are quite popular among elderly people. Say we're working on the Chinese medicine development blueprint. We need to see how we can enhance the role of Chinese medicine in elderly healthcare services. We need to provide convenience for the elderly in Hong Kong to use traditional Chinese medicine services. In relation to the integrated Chinese Western medicine services, we can promote prevention and treatment for elderly people in Hong Kong. Say hypertension, we can use integrated Chinese Western medicine services for complementarity. For example, in the CDCC pilot scheme, we can introduce traditional Chinese medicine referral services. in order to achieve complementarity between Western medicine and Chinese medicine. DS. Thank you. We do attach a lot of importance to Chinese medicine services, which are popular among the elderly in Hong Kong. They place great trust in TCM. We have already recruited the Commissioner for Traditional Chinese Medicine. He has a background in traditional Chinese medicine, and we're working on the Chinese medicine development blueprint with the help of the Commissioner. For the Chinese medicine hospital, we have inpatient and we have outpatient services. For some particular diseases, traditional Chinese medicine may have an edge. So in primary healthcare services or in traditional Chinese medicine services, we do want to make enhancements and promote the wider use of the TCM. As for the scheme involving the GBA, most integrated hospitals have the Department of Traditional Chinese Medicine. On integrated Chinese and Western medicine services, there is a scheme not covered by the document, but it is covered in the policy address. In the HA system, we have collected a wealth of data. So for CMCTR, that is Chinese Medicine Clinics Training and Research Center, we have certain data and statistics. We need to think how to make good use of all these pieces of information. We need to achieve complementarity and a positive impact. So in the future, when we develop Chinese medicine or when we want to promote Chinese medicine to the international arena, this will be helpful. We have added respiratory diseases as well as cancer treatment, and we are still adding more types of diseases. Thank you. My turn. Today we're discussing the medical service needs of the elderly. The long-term needs of the elderly are important. There is no denying that we have an aging population in Hong Kong. There will be more elderly people in Hong Kong, so we need to ensure a sustainable development for the local healthcare system, especially in relation to the provision of services and the costs. The document mentions what is being done under the blueprint, but what about ensuring the sustainable development of the local healthcare system? Let's see if the DS can supplement. Next, I'd like to hear more about supporting cross-boundary elderly services. We went on a visit, and we are alive to the greatest challenge, which lies in the healthcare sector. Healthcare vouchers were rolled out last year. The usage rate was quite good. Do you have more information to share with us? Say which type of diseases or where were the vouchers used so that we can target particular diseases or locations, and we can do more in this regard.
Deputy Secretary, let me address the other questions first on the elderly healthcare voucher scheme in the GBA. Perhaps I can provide you with some statistics. After the launch of the scheme, we find the scheme very popular. As at the end of December, there are 7,200 eligible elderly people who have used services under the GBI pilot scheme. There have been 1,000 to 12,000 applications. So we see that there is a keen demand for this scheme and that elderly people have been using the vouchers. On specialist healthcare services, we see that elderly people have been using the vouchers for health checks as well as Chinese medicine services. Elderly people have been using the vouchers for dental services as well. We have the 2 dental institutions in the GBA under the scheme. And participants of the scheme have been using services offered by these institutions. So on oral or dental care, as well as prevention and management of chronic diseases, elderly people have been using the vouchers. The hospital authority has been projecting the manpower needs, and we are looking at the demographic distribution and structure in the coming years. Under the hospital authority model, we look at the demographic distribution in each cluster. We also look at the distribution of CSSA recipients as we plan our services. For the details, perhaps I can ask Dr. Cheng to tell you more. Thank you, Chairman. The model that we use is to project not only the increase in population in the coming 20 to 30 years, we also look at the speed of aging population. For elderly people aged 65 or above, we see an increase of 3% every year. We also look at the prevalence of chronic diseases of these elderly people in each district. And then we look at the demand for hospital beds in each district. We do not only adopt this model to make an estimate, we also look at whether there can be sustainable healthcare services. We do not want to cut down on expenditure. We want to make use of technologies to help save costs and ensure the sustainable development of our healthcare system. There is a regular mechanism in the secondary and tertiary level of the healthcare system to deal with all these. Mr. Paul Che, speaking for the first round. Thank you, Chairman. This subcommittee is to study population policy and initiatives, and in this particular meeting, we look at the medical service needs of the elderly. I very much agree with what the members said. However, this entire paper looks at primary healthcare services in Hong Kong. A lot of people in Hong Kong, they aren't from the grassroots. We also have lots of people in the middle class. However, the government does not take good care enough of the middle class. It's not that we should not take care of the grassroots people, but we have neglected the middle class. To give you an example, we do not have allowances for people who reside with their parents. Yesterday, I was in the Typo market and I was asked this question. The person has $500,000 of MPF savings and he could not use it to deal with the disability problem. We have many different types of people in Hong Kong, so I want to express my view on this. Primary healthcare initiatives are being rolled out, and they're good initiatives under the hospital authority. However, they aren't able to address some serious issues in Hong Kong. I think we can do more to help elderly people to live with more dignity. The movie The Last Dance has been very popular. The movie touches on a lot of issues, including life and death, as well as elderly people who need care. The main male protagonist in the movie, Michael Ho, he was taken care of by his daughter before he died. However, a lot of people in Hong Kong, they have no one to take care of them. It's not just about money or a place to live. It's about whether you have someone to take care of you. I think hundreds and thousands of households in Hong Kong, they have chosen to move out of Hong Kong, especially those in the middle class, and a lot of elderly people are left alone. Some young people are imprisoned or are on bail, and their family members are under great mental pressure, and there are no policies to help them. I might have digressed a little, but I think we have to take care of these people. This paper mentions about end-of-life care. Many friends around me that I know are incapable of taking care of their family members. We're spending some $3.33 billion on elderly healthcare vouchers every year. We also spend at least $1 billion on elderly health centers. I don't need the administration to respond to my comments. I just want to say that I appreciate what the government has been doing. I am just giving you some examples so that you can consider the mental health as well as psychological health of the middle class, and you can come up with a priority as you allocate your resources so that our elderly people can live with dignity. We want to be people-oriented. We want the resources to be used effectively. Otherwise, it's not going to help much. Any responses from Mr. Edley? To give a quick response, I think we need an overall planning for the medical service for the elderly. I want to clarify one point. We mentioned a lot about primary healthcare development in the paper. We're not referring to just support and services for the underprivileged or the grassroots. We are emphasizing the primary level of the healthcare system. Some people misunderstand that we are focusing only on the grassroots people as we roll out primary healthcare services. So we aren't neglecting the middle class. For example, we have the chronic disease co-care scheme as well as the community pharmacy program. All these initiatives are offering subsidies for people to get healthcare services. On end-of-life care for elderly people, as we all know, we have already passed the Advanced Decision on Life-Sustaining Treatment Bill. We will emphasize more on advanced care plan for elderly people. If we get it right, we will be able to offer more care for elderly people. Thank you. I think we are wrapping up this item. I thank the representatives from the Health Bureau for attending this item. Now we move on to the second agenda item, planning for the elderly service needs of the elderly. Let me invite the government representatives to enter the meeting room.
好，咁今日呢，出席嘅官員係包括有勞工及福利局。
We have Mr. Ho Kai-ming, Undersecretary for Labor and Welfare, and Ms. Jenny Yan, Assistant Director of the Social Welfare Department. Members who would like to speak on this item, you may press the button now. Meanwhile, I'll invite Mr. Ho to walk us through the paper. Thank you, Chairman. I brief members today on the relevant government measures relating to planning for service needs of the elderly. There are mainly two parts. The first part is to offer care services for frail elderly persons. We adopt the aging in place as a core institutional care as backup approach. We perform standardized care need assessment mechanism for elderly services for frail elderly persons, and those who have done the assessment may apply for subsidized community care services or residential care services. The government has incorporated the population-based planning ratios for the provision of subsidized elderly services in the Hong Kong planning standards and guidelines. We cope with the service needs on different fronts. For example, we provide different types of places, including asking NGOs to offer residential care services. We also buy places from the private sector. Also, we leverage market forces to enhance the capacity of our services. We offer community care service voucher scheme as well as residential care service voucher scheme. We adopt the principle of money follows the users, and elderly persons can freely choose the services they need under the scheme. Also, we adopt the principles of co-payment and affordable user pays more to ensure the sustainability of the provision of elderly services. We also support cross-boundary elderly services. Eligible persons may join the residential care service schemes in Guangdong, which cover meal and accommodation. The number of participating healthcare facilities has increased from 4 to 11 under the Guangdong Residential Care Service Scheme. The government is commissioning organizations to help offer services to participants under the scheme. Also, we encourage the provision of RCHEs in new private developments. We offer GFA concessions to enhance incentives of the private developers to provide RCHEs. We also offer community support services for elderly people who can take care of themselves. We promote active aging and gerontech. Some 200 centers offer services for elderly people in Hong Kong. We promote healthy aging through these centers. We also strive to identify hidden elderly people who need help. The government will continue to stick to the Hong Kong Planet Standards and guidelines in rolling out elderly service centers. The government also injected $80 million to the Elderly Academy scheme. We also have the opportunities for the elderly project to enhance elderly people's sense of achievement. We encourage the use of gerontech at the same time. We have the Innovation and Technology Fund for application in elderly and rehabilitation care. which subsidizes rehabilitation service units to procure, rent, or trial technology products. In year 2024 to 25, the government will inject an additional $1 billion into the INT fund to cover gerontech products suitable for household use. Overall speaking, we roll out different measures to help elderly people. Thank you.
簡介咁贊
Thank you, Undersecretary. 6 members have pressed a button to request to speak. They are in order: Dr. Lawai Kwok, Mr. Bill Tang, Ms. Judy Chan, Ms. Eunice Yong, Deputy Chair, Mr. Dennis Lang, and me myself. 5 minutes, questions and answers included. First member, Dr. Low. Thank you, Chairman. We need to provide elderly services to the elderly in Hong Kong. We need to respect them. The Undersecretary mentioned an array of schemes to support elderly service needs. And I think supporting cross-boundary elderly services is a good policy. We have the Guangdong scheme, and we also have the other scheme, that is to allow elderly people to retire in Fujian. These are measures for supporting cross-boundary elderly services. Say we have the residential care services scheme in Guangdong, and elderly people can choose which residential care homes to stay in. The Hong Kong government provides support in this regard. When it comes to Fujian, we went on a visit. We saw that quite a lot of residential care homes are doing quite well. They provide related services. So elderly people from Hong Kong who are staying in the care homes are satisfied with the services provided by the Guangdong care homes. Earlier on, I went to Shanghai, and they asked the same question. When Hong Kong people retire, they want to return to their birthplace to spend their retirement. They actually have close ties with their place of birth. So I'd like to see that the coverage of the scheme to be expanded. Say, for the Guangdong province, well, I think there are probably more Hong Kong elderly people retiring in Guangdong, given the close proximity between Guangdong and Hong Kong. For those that are not as near, there is also basic support. But we need to expand the coverage of these schemes. We've heard similar views in the community, so I'd like to see if the administration has any policies in this regard. Undersecretary, thank you, Dr. Low. Let me share with you some figures. Guangdong and Fujian schemes. 26,000 people are on the Guangdong scheme. For Fujian scheme, the number is only 2,000 odd. We can see a great difference between these two schemes. For Guangdong, about 1/10 of the fees. We don't rule out the possibility that we will provide similar services in other municipalities and provinces. We need to work with the Department of Civil Affairs of different provinces and we have started our talks with the relevant counterpart in the Guangdong province. So we rolled out the relevant scheme as announced in the policy address. Elderly people in Hong Kong haven't taken out any medical insurance policies offered in mainland China. How can we allay the concerns of the elderly in Hong Kong so that they will choose to retire in the Guangdong province? We can go to Fujian when the situation is mature enough. There are 5 cities. We need to develop the 9 cities within the GBA before we further expand into the remaining parts in Guangdong. Well, of course, there are more Hong Kong people who have their place of birth in Guangdong. Fujian may rank 3rd. In this regard, the burden on Hong Kong can be eased. Mr. Bill Tang. Thank you, Chairman. Well, it's actually common for people to retire in mainland China, and probably the Labor and Welfare Bureau can take the lead. We can put in place some funds and to see if these funds have any constraints. We can take stock of the existing schemes. We need to provide convenience in order to deal with the situation. We need to reduce red tape. The administration mentioned frail elderly at the outset. That was mentioned in the introduction. From the perspective of policy, frail elderly are elderly people who have impairment levels in the functional performance of daily activities with reference to the standardized care need assessment mechanism for elderly services. For some that are staying in private residential care homes, these elderly people may not have gone through the standardized assessments. For some elderly people, they may already have a poor physical condition. They have medium impairment levels, but they have not gone through the standardized care need assessment. We need to take a holistic look at the elderly service policies. So elderly people may require varying levels of support, assistance, and intervention. So we aren't just focusing on frail elderly. Last week, I invited Mr. Ho, the Undersecretary, to one of the sharing sessions held by me. If we want to improve neighborhood relationships, if we want to allow care teams to play their role, a register for the elderly is very important, not least elderly singletons. We need a register containing information of the elderly caring about the elderly. We need to provide information. The government needs to take a proactive approach. Hidden elderly won't open the door for you to let you in. As for drone technology, say doorbells, if they have become necessities of a home, for example, we oftentimes talk about smart water meter. So if an elderly person hasn't stepped out of the flat or used the water in say 24 to 48 hours, then we need to notify the government or care teams. We can let the elderly people choose whom to notify. Elderly people aren't even willing to spend on safety bells. That is in the EAS system. We also need to locate common Jurong technologies, say as common as doorbells, that will allow identification. Thank you, Chairman. For different funds, they have their own explanation for use, so we will study the situation after the meeting. In relation to the standardized care need assessment mechanism for elderly services, it's free of charge. I hope members understand the elderly services in Hong Kong are very different from those in mainland China. In mainland China, elderly people can choose to buy different services, so the situation differs from that in Hong Kong. In Hong Kong, we need to accord priority to different groups of elderly people, and we put the frail elderly first right now. That's the policy that we can afford. But of course, we'll continue to look into the views put forward by Mr. Bill Tang. We are exploring Jurong technology, and I'd like to ask Ms. Jenny Yan to talk about the standardized care need assessment mechanism for elderly services. Thank you, Chairman. There are two parts to the assessment mechanism. For mild impairment level, say elderly people can go through a simple standardized care need assessment mechanism. Then the elderly can take part in some services in the community. For frail elderly, they will have to go through the standardized care need assessment mechanism. These elderly people can pay affordable price to opt for the services that they require. In society, we are ramping up publicity efforts. So elderly people can seek help from medical social workers or elderly health centers. With the help of care teams, many elderly people have been referred to the Elderly Health Center for assistance. Thank you. Next member, Ms. Judy Chan. Thank you, Chairman. The topic of elderly services is getting more and more important. We have a rapidly aging population. In the administration's papers, we can see that the slogan is aging in place as a core, institutional care as backup. We all go along with this slogan, but the feeling that I have is that the resources are tilted towards institutional care. However, no matter how much we talk about Jurong technology and community participation, it is difficult to promote this message enough. That is, the aging in place as a core. It's difficult to promote this message. We need to drive aging in place as a core, and we need to ramp up efforts to promote this message. Let me give you an example. In the coming 10 years, 1/3 of the local population will be elderly people. We need cross-departmental or cross-bureau efforts. Just the Labor and Welfare Bureau alone cannot deal with all the matters. Say Jurong Technologies, we are holding fairs, or we are waiting for people to come to us to rent the pieces of equipment. However, for newly built public housing estates, can we provide during technologies that are suitable for frail elderly people before population intake. We can have them ready before population intake. We have district health centers, and I do think it can play a bigger role in this regard. It's not under the purview of Labor and Welfare Bureau. So in this regard, how can we put in place a better mechanism to promote aging in place? The principle of aging in place as a core is simply a slogan to me. It's difficult to implement it right now. Thank you.
Undersecretary, how to better promote aging in place? Can share with you some statistics. We do not only allocate resources to community care services. Under the standardized care need assessment mechanism, the number of people who go to RCHEs, take 2019 as an example, there were 19,000 people who went to RCHEs, and we had 10,700 people who received community care services. This year, from October 2023 to September 2024, those who went to nursing homes or elderly care homes, there were 21,000 people, and 16,300 people received community care services. So you see that we are stepping up support in community care services. A lot of people, they opt for home-based care services or they go to daycare centers. And they are invisible compared to elderly people who reside in residential care homes. However, the truth is that we have been stepping up the services for community care. Some elderly people, they are on wheelchairs and they may not be able to enter certain facilities easily. So we will put in resources to modify their accommodation. Assistant Director. Undersecretary just now mentioned some figures under the standardized care need assessment mechanism. Over the past 5 years, we have seen a change in the provision of services. In the past, we had more people who are applying to get into elderly care homes. However, now, elderly people aged 65 or above who reside in elderly care homes, they only account for about 4%. But we also have 4% of elderly people who opt for home-based care services. So you are still emphasizing institutional care as backup and aging in place as the core, right? Under the new standardized care need assessment mechanism, if you need community care services, you can wait for such services. And for those who need institutional care, but their family members want to wait for community care services, they can still do so. So most elderly people nowadays, they wait for community care services first, and then they will be put in the line for institutional care. For newly built public housing estates, can there be Gerian technology products incorporated into the design? We will talk to the Housing Bureau about this. Ms. Eunice Yong, Deputy Chair. Both agenda items today are about planning for the elderly service needs. The government should have conducted large-scale surveys to understand the service needs of the elderly. So my first question is whether the government has any plans to conduct surveys to learn about the needs of elderly This will include their service needs as well as healthcare service needs. Like Dr. Low said, we want to know how many elderly people want to retire in Fujian province or other provinces in the mainland. So far, we have only seen the number of people who have been to the mainland for retirement, but we don't know how many people are interested in going to the mainland for retirement. If we have the relevant figures, we will know whether we should put in resources to, for example, those in Fujian province or other provinces. The government should think about offering support to elderly people from Hong Kong residing in the mainland. They look for members of the Legislative Council when they need certain support and healthcare services. So my question is whether there will be a large-scale service to understand the needs of the elderly. My second question is about aging in place. A lot of people from the middle class, they opt for aging in place. They have been perhaps renting a place to live since their 40s or 50s, and they don't have their own property. And when they reach the age of 60 or 70, they can no longer rent an apartment on their own. So will you educate property owners about what they should do when they come across elderly tenants? Some people, they have been renting a place to live for most of their lives, and these people may not need grassroots or primary elderly services, and they are not qualified to be admitted to residential care homes. So will you educate property owners about this? My third question is about Gerion technology. I've been to a Gerion Tech Expo recently. I saw many elderly people there. Many of them are concerned about what kind of Gerion Tech might benefit them. For those with visual impairments, they want to look for devices that can help them see, and some of them look for soft meals. Like Ms. Judy Chen said, these new technologies and products are only provided in residential care homes. Our party has been supporting an activity on promoting Gerion technology. We want to make good use of community services. I think this Gerion Tech Expo that I went to was a great one. And it was right next to an expo about Chaozhou, and so visitors might be interested in going to both of these events. We want to create synergy when we organize these events and activities so that elderly people can understand that by using technology, it can help them live with dignity. We also want to alleviate the burden of carers of elderly people. Undersecretary, I thank Ms. Eunice Yung for the questions. The first question is about the needs of elderly. In 2017, we came up with an elderly care plan. Of course, these figures keep changing. However, the overall trend is that we will stick to the survey conducted in 2017. Some GBA cities, after the 14th five-year plan, have rolled out measures, and we stick to the same direction for subsidized services. Until 2036, we need 54,000 such places, and currently we can offer 44,000 places, and we're catching up with the gap now, and we are procuring services from different sectors so that we can offer the services for elderly people. Of course, it's hard for us to guess what elderly people want. However, we can tell from the waiting lines that the waiting time for subsidized places is 19 months, and for bought place schemes, the waiting time has been 3 to 4 months. So We can tell from the waiting lines which types of services are more popular, and we will make adjustments accordingly. In terms of education on property for property owners, we'll talk to the Housing Bureau. Thirdly, on gerontech products, a lot of these products have gone to the community now. In the past, these products were more popular in residential care homes, but it's not the case anymore now. Two fast chain restaurants have provided soft meals now. For elderly people from the middle class, I think we need to tell them where they can get these soft meals. There are other types of products used in elderly care homes. So we have devices and products used in elderly care homes as well as those used in the community. As mentioned in the policy address, we will continue to promote silver economy. And by providing these gerontech products and technologies, we can help promote the silver economy. Chairman, I do want to say that the soft meals actually taste very good. They have soft meals for roasted goose. We also see the different types of promotion of these kind of meals by, for example, the Tonghua groups of hospitals. And we hope that more elderly people can benefit from these soft meals. Mr. Dennis Lang, Chairman, I am a consultant of an elder academy. I also took part in the Opportunities for Elderly project. Undersecretary mentioned about the government's policy direction of aging in place as the core institutional care as backup. However, I don't see how the government has been promoting aging in place as the core. Many elderly people nowadays choose to age at home. I know some elderly people aged 80 or 90. They have fallen a couple times, and we convince them to reside in residential care homes instead, where they can get people to help wash their clothes. They can get them food they need. We see many singleton elderlies as well as elderly people who live alone in the community. They want freedom. They don't want to be confined in elderly care homes. Also, I think the elderly care homes, they do not opt for a very human approach in the way they arrange their beds. They have, for example, 5 beds in one room, and only one of the residents in this room is relatively healthy, whereas the 4 other residents might often complain about their illnesses. So for organizations that win the bid or contracts, can you give them guidelines on how they can improve their services? Also, Undersecretary mentioned that the government adopts the principle of money follows the users. And this approach is adopted under the Residential Care Service Voucher Scheme. My family members have used this voucher. I think this voucher can hardly benefit family members of elderly participants. For daycare centers, they may run for 8 hours a day, but for residential care homes, residents, they go to the care homes at, for example, 9 a.m., and by 5 p.m. they have to go home. They often have to take the shuttle bus at 7 a.m., and It takes them half an hour to get to the care homes. And after they take breakfast, they have to get onto the bus again. This is because the shuttle bus has to go through different points before they send the residents to their homes. The problem is that these residents, they have to get home by 4 p.m. The family members of these elderly people, they are busy at work and they may only get home by 10 p.m. and it's hard for them to take care of their elderly members. So can daycare centers or daytime residential care homes provide longer services? This is how you can promote aging in place as the core. And I want to hear what the Undersecretary thinks about this. Can you leave time for the administration to respond to your questions?
Thank you, Chairman. I'll ask the Assistant Director to take the second question. In relation to the first question, we'll try to provide coordination in relation to the places at residential care homes. It's difficult to give you information about private care homes right now. There are not enough places in public residential care homes. If there are elderly people who refuse to undergo the standardized care need assessment mechanism, it's indeed difficult to convince these elderly people. But we do need an objective tool to assess the physical condition of elderly people before we decide on how to help them. The assessment is actually straightforward. It doesn't take a long time. The information collected is far more useful than I thought. Other organizations will carry out home modifications based on the results of the assessment mechanism. These are not paid for by the administration. It is actually the decision of the elderly. We want to know what kind of facilities or equipment is suitable for the elderly. In relation to another question, I will ask Ms. Jenny Yan to give you more information. Thank you, Chairman. Thank you, Mr. Dennis Lang, for your question. In relation to daytime care services, as the Undersecretary said, when an elderly person is waiting for the services, there's a wide range of services available. In relation to daytime care center services, for those using social care vouchers, each session is 4 hours. And we can provide services on an hourly basis. We can provide services flexibly. And the principle of the vouchers is money following the users. Users can use a mix of different centers. Family members will have peace of mind when elderly people are taken care of at daytime care centers. While for vehicles, it takes time to receive all the elderly people, and we'll have to make arrangements with the operators in order to see how to make enhancements to the arrangements. Thank you. Next, myself. I'd like to ask about drone technologies. Earlier on, $1 billion was given to the different organizations to implement the INT fund. There are quite many views in society. In recent years, I believe quite many organizations have applied for the fund, but then equipment may not be useful enough, or they don't have sufficient space to house all the drone technology equipment. Apart from giving them money to rent or buy equipment, what resources do we have in place in order to help them make good use of these resources? It's very important to use these pieces of equipment or technologies to good effect. Are there any arrangements in relation to the transfer of drone technology equipment if they do not suit any particular organization? I learned from the paper that the government would inject an additional $1 billion into the INT fund. I understand this is something new. Do you have any timetable? How will you use the additional $1 billion? In relation to the Elder Academy Development Foundation Fund, as I understand, elderly people want to learn. They want to acquire more knowledge. There's an elder in my family aged 75. He or she has 3 eyes, but is still keen to learn. He or she wants to have a common topic with other family members. If we could have silver hair slashers in the community, then it's also one of the ways for them to keep their finger on the pulse on the community. We want to encourage more elderly people to learn. We hope more universities and secondary schools can provide programs. But of course, this requires the commitment of different schools. International ranking is important. We understand this, but we also want them to devote themselves to community work. It's not just about learning. Many NGOs encourage elderly people to start their business or to try something new. This may allow them to carve out their second career in life. So it's not just about learning. Some elderly people may opt to start their career. This will be discussed in the working group on promoting silver hair economy led by the Deputy Chief Secretary for Administration, Ms. Jenny Yan. Thank you, Chairman. Just now we talked about the INT Fund for Application in Elderly and Rehabilitation Care. As we mentioned, an additional $1 billion would be injected into the fund. Elderly care organizations and residential care homes buy various drone technologies to help elderly people, say those in relation to occupational therapy or physiotherapy. We're going to buy more products which can be brought to the homes of the elderly people for their household use. In addition, we also mentioned vouchers. Last September, when we regularized community care service vouchers, we covered 12 drone technologies that are suitable for household use. they are used by users of the community care service vouchers. We require service providers to draw up a personalized care plan for the elderly person concerned. We'll see what kind of drawing technologies are suitable to be rented for household use. So there is follow-up service to see what kind of equipment is suitable for household use. I'd like to follow up. It's important to know that the equipment is used well and correctly. So in the follow-up, the administration can follow up in this area, and we have Mr. Dennis Leung to speak in the second round. Thank you, Chairman. Just now, I expressed my views. I hope the Undersecretary will study my views after the meeting. The administration needs to reform. The wait is long for the Bob Play scheme, we understand. If elderly people are in good shape, and if they are in good mental state, then we'll need less of these services in the future. If we follow the principle of money following the users, and if we can provide better services in daytime care centers, then carers can take care of the elderly and the elderly can go back to their home. I hope the administration will consider making enhancements to the services. Thank you. Undersecretary. Just now I touched upon it as well. It depends on what kind of residential care homes, after all. And it takes 19 months to wait for a residential care homes. For the Bob Play scheme, it takes around 3 to 4 months only. And for elderly people who are willing to go to the GBA, then they can secure a place right away. If, however, you must secure a place in a residential care home operated by NGO, then of course you have to wait. We have residential care home voucher, and elderly people can secure a place through this scheme. We should consider a wide array of options. We shouldn't just target the residential care home just off your residence. For residential care homes not operated by NGO, actually you can secure a place right away. So I hope members will relate to elderly people the situation. Of course, they can visit the SWD for the latest information. Well, Chairman, this is not exactly what I asked. The Undersecretary has his own views, I understand. I'm not saying that you have to keep providing more resources. Everyone wants to get admitted to residential care homes that are subsidized. The principle of money following the user's daytime care centers, when elderly people don't have to stay in the residential care homes or daytime care centers, then the problem can be solved. But probably I didn't express myself clearly enough. All the services are subsidized by the government, and there are vouchers. Elderly people can receive services right away. If, however, they choose to use the vouchers, whether the residential care services or community care services, they can secure a place right away. It's important that we know the physical condition of elderly people, then we can provide services right away. All members who have pressed a button have already asked questions. Agenda item number 3, AOB. There is no AOB today. The Secretariat will inform members of the next meeting date. So this is the end of this meeting. Meeting adjourned. Thank you.